Well, thank you everyone for joining us tonight. My name is Kathy, and I'm part of the marketing team here at Surgical Specialties. So this webinar will be about 30 minutes, and we'll have time for Q&A at the end. Dr. Raynham?
Well, thank you so much, Kathy and Tim, for inviting me to give this webinar on the Quill suture and what it's done for my practice. It's made a huge difference, and I've been using this suture for about, I'd say, 3 to 4 years, Kathy and Tim, I think, and it's been magnificent. So, of course, before the pandemic, all of us were operating at full capacity, and then the pandemic hit. And then very soon, elective procedures were postponed, especially during the peak COVID months. And here's a nice little slide showing what happened during May 2020. You can see the darker areas are where there's about 99 to 100% decline in elective surgeries. Interestingly enough, you can see in the center, north center of the country, you can see there's a yellow area. So they obviously were still working pretty fiercely. And you can look at Massachusetts, where I live, top right, it's black. So we really had no elective surgeries. The only surgeries I performed were for skin cancers, and there were really a select few skin cancers surgeries that I performed. So now we're in a slightly different phase. There's some kind of recovery, although you never know, there might be another wave coming up. So surgical capacity is still quite limited. And many of us will think, what can I do to increase my surgical capacity with all of these regulations? There's so many of them. You know, our patients now have to wait outside and they're called to come inside. We have fewer patients in the actual office space, almost nobody inside the waiting room. And then we also have to make our staff follow different routines. They have to call the patients, do the patient screening, keep communicating with them. So it's a lot more things that we have to do now than we had to do in the past. So what's great about the Quill suture is it helps save time. And so in saving time, I can then have more patients coming through for procedures. So here are 3 key features about Quill. And you can see, first of all, it's quite short. And that's one of the greatest things actually about the Quill suture, is we don't have it flopping around, or maybe an assistant holding the suture so it doesn't get in your way. It's really short. It's about 20 centimeters. And even the 20 centimeter suture is great for melanoma cases. I recently closed an 8 centimeter melanoma incision. And at the end, after I was using the 20 centimeter suture, I still had quite a lot left. So that's really a great feature of it. So number 1 also is we have a very high performance needle. It's bigger than the PC1 suture needle, of course, that we have on the fast absorbing gut. And what's great about this needle is that I need fewer passes. So maybe one excision I have to pass the fast absorbing gut maybe 10, 15, 20 times. When I'm running the Quill, I have to only have far fewer passes, and therefore with less bites, it's quicker. I can move along more quickly. And then number 2, in the middle bottom of the slide, you can see the barbs. And these are arranged in a helical pattern along the suture for maximum tissue engagement. And then the 3rd feature, which is really great and that makes this whole process happen, is that we have an adjustable loop for simple anchoring. And this is the loop through which we pass the needle and tie the initial anchor. And then we can run it along. So let's get to the next slide. And here's a little video, a very short video, to show you how the barbs work. And we're going to look at the suture that's going from the right to the left, and then it's going to move back and engage in the tissue. So here we go, moving from the right to the left. You can see it moving. And then we're going to pull it back in the opposite direction, and you can see it engaging, and it's stuck. It will not move anywhere. And sometimes this engaging can happen when there's, the actual forces of the excision, when it wants to go back to its original position, that actually sort of makes it go tight again when it's caught with the suture. So I'm going to play it one more time, just so you can see it's moving towards the left, and then as you pull it back, or as the tissue wants to expand again, it gets caught, and it actually engages and fixes the tissue in that position. So we'll go to the next slide. And here's a great little video, little cartoon video of the Quill suture. And in this particular video, you can see that the Quill suture is being used deep and on top. Now, most times I will, on the trunk, I use interrupted sutures, whether it's vicryl or monocryl, and then I will run the quill suture on top as a running subcuticular suture. But sometimes in other parts of the body, for instance, in the retroauricular area and in the preauricular area, I'll use the quill suture, most often in this space, in the foromonoderm suture, and I'll use it in the deep and superficial layers. So here is an example of using the quill suture, deep and superficial. And the great thing about this, of course, also is that just using one suture, it's very economical. So here we go. And there's a little intro here. You can see the close-up of the quill suture and the needle. Okay, so here we're starting. And with this suture, we start obviously at one end. And sometimes, by the way, I'm just going to stop it just briefly. What I'd like to point out is very often, you like to match up the incision so that it's equal. You divide it in halves and quarters. And so what I sometimes do in order to make sure that the one side is matching nicely to the other side is I will draw and put little pen marks on with my surgical marker, maybe a central one so that each side will match, and then one on either side of the central line so we can have a very uniform incision. So we'll continue. So here we are doing the initial suture and pulling our suture needle through, and it locks the suture now. So we pull tight, and then we're going to continue to run, just like like a deep suture, but running it underneath without the interruption. And of course, I don't have to tie knots. You can see how quickly it goes. It's really quick. And here's a close-up of the barbs going through and then engaging and locking in the tissue. And you continue here. And I actually did a deep and superficial. You can see running through here this afternoon, and I tied myself like 5 to 7 minutes for one on the neck. So here we're coming through, and this is just like a running subcuticular proline. It's very, but quicker, because we don't have to tie that fancy knot with a proline at either end, and you don't have to worry about losing that proline or having a difficult time taking it out. So you can see how beautifully it comes out, and then look at this last little place. So you can see here. So what happens is that, let's just rewind a little bit if we can. So let's pull back a little bit. So you can see that when I'm finished, I take the needle and I go back into the incision, and then I come out at the side. So here we go. I come out at the side, and then I just pull it tight, and then I cut. And so you can see that I actually don't even need an assistant. And that's what's also very valuable about the suture. All right, so we'll move to the next slide. And so what Quill essentially does is it eliminates suture knot tying and reduces the closure time by up to 50%. And in doing this, I actually managed to see far more cases than I used to do when I had to tie many of the interrupted knots, and certainly knots at the top of the incision. And as I mentioned, we can remove the closure bottleneck and increase the patient volume by at least 50%. As I mentioned, we don't need an assistant. Sometimes when I'm running the top suture, I'll ask my assistant to unglove, and she can start then with the discharge paperwork, and also clean the room, but or maybe move on to the next patient and get the next patient ready. So that's really very, very valuable. And the great thing also about Quill is that these sutures are very fully absorbable. So the patient does not need to come back into the office for suture removal. And if a follow-up visit is needed, we can do it virtually or ask the patient to send their photographs. And I know that some of you during the COVID time might be using the fast absorbing gut, either the 5-0 suture or maybe the 6-0, if you can get some of it. And the disadvantage of those sutures, the 5-0 fast, being so superficial, of course, in my more elderly patients, I'm not too worried about visible track marks. But in my middle-aged and younger patients, I'm always worried that I'm going to see those suture marks. And I'm constantly reminding the patient to moisturize well, to add a lot of Aquaphor or Vaseline, because I just don't want to see any track marks. And with the Quill suture, when I use it on the trunk and extremities, sometimes in the preauricular and posterior auricular areas, I never have to worry about those track marks, even with the dissolving sutures, especially in my younger patients. And what's great about them not coming back is I can then use those rooms to room a patient to keep them safe, and also maybe add an extra procedure in one of those rooms. So definitely it simplifies my workflow and it increases my patient volume by not having them come back into the office. Of course, we can still see them virtually. So this is a patient who had I think I harvested a graft on her in one of my Mohs cases. And sometimes I like to choose the nasolabial fold because I feel that the skin match, the texture is really good on the nose. And for this one, I believe I used the interrupted sutures underneath and then a running subcuticular quill suture, the 4-0 monoderm. And you can see she came back in about a week and she almost has the effect of having a little filler there. It filled in a little nice, it gave some extra volume there, the nasolabial fold. And then a month or two later on, you can see she came back. She was very happy with the result. And it's very smooth and no suture marks. Here's another man who came in, one of my regulars, and he had a basal cell carcinoma in his left upper chest. And for his excision, I used the 3-0 monocryl deep interrupted, and then I just ran the top suture with a 3-0 monoderm. So I do a 3 and 3. And of course, the 3-0 monoderm is on the PS2, so it's a very big needle. And the 20 centimeter, the shorter one, because I really don't need a long one. And just having the short suture is just so easy to handle. I don't have to have that suture getting in the way. Then you can also see underneath the incision, on the bottom right of that incision, you'll see that there's an older surgery site with some track marks. And that was done a few years before he came to see me. And I want you to see and take note of those track marks. And then we're going to go to the next slide. And you can see he came back a year later. In fact, I think he just came to my office last week and I wanted to get some extra slides and cases for you. And I sort of took a quick picture of him. And you can see a close-up on the right. And in the green is the quill. And then the red circle shows the previous surgery with the track marks. And I want to, again, focus on the quill outcome. And pretty much with the quill, I almost always have a very uniform thickness of the incision. And also, I think this is also due to the fact that I have maybe in the high tension area, some of the interrupted sutures. Though Tim is telling me that now with the newer quill, the 3-0, that they've got more barbs per centimeter. And so that I might be able to use it on its own in high tension areas. And I'm slowly going to start trying that out as well. But for the meantime, on the chest and back, I still will use the 3-0 monocryl, and you might want to use the 3 or 2-0 vicryl, and then I will run the 3-0 monoderm on top. So, and then you can see it's got a really great outcome. And then I add the steri-strip sometimes because I really focus a lot on cosmetic outcome, and I find that having the large steri-strips on top doesn't interfere with any suture underneath, and it just gives that extra little great effort to keep the incision together. So here's another case. This is a man, another frequent flyer. And I think I got another photograph of him about 3 weeks later on. And you can see here on the top left, it looks a little tight and looks a little ruffled. And I always reassure my patients never to worry about it looking ruffled. Some of my staff sometimes say that might look like a little snake underneath the skin, but it really flattens out beautifully. And sometimes the more ruffled it is, the better outcome I get. And I know that some of you might see a little ruffling when you do your proline subcuticular sutures. I do the same here with the monoderm, and I have a great outcome. So always, of course, reassuring the patient it will flatten out. So that was 3 weeks. And we're going to go then to 1.5 years after the procedure. You can see the same area on the top left chest. And you can see it's definitely flattened out. And if you look at the close-up, you can see that the incision is very, very thin. The line is very, very thin. And you don't see any track marks. And the patient is very happy. Maybe a little erythema, and if the patient is bothered, you can always V-beam it out. But most of my patients are just very satisfied with this. And here's another case, a man with a basal cell on his left lower back. And you can see the follow-up 1 month afterwards. And it's beginning to flatten out a little bit. And then 1.5 years afterwards, no track marks. And he was happy. I'm going to move to the next slide. So I'm sure that many of you might have some questions, and we would love to answer them. And I know that Kathy, you often get quite a few questions in 2 different areas. Is that right, Kathy?
Yes, yes. So I just want to do a quick to let everyone know that to ask those questions, you can look at the bottom of your screen. There's a Q&A function. So once you click on that screen, the Q&A window will pop up, and you can type in your questions, and I will see them come through, and we can ask Dr. Helen Raynham those questions for you. But in the meantime, we do get frequently asked questions, as you mentioned, and I wanted to ask you, can you talk a little bit more about your experiences on how many more surgical cases you see in a day when you use Quill?
Yeah, absolutely. So before I would basically maybe do 2 very large melanomas in an hour, and now I can get up to 3. And these are pretty big cases, and it's just because of the Quill, and managed to speed through the top closure rather than having multiple passes with the fast-absorbing gut. I can just do a very quick superficial running subcuticular with the Quill. That helps a lot. And then also, as I mentioned earlier on, that well, today I thought I'd time myself because I wanted to report back to you guys about how long it took me. And I had a young patient, I think in their 20s, who came for an excision of a cyst on their left neck. And I think it took me about 10 minutes. And I used the 4-row monoderm Quill suture. So that was the 4-row on a P3 needle. And I used the suture for both the deep and the superficial. It was very quick, about 10 minutes max. And they were very happy. It might look a little ruffled in the beginning, but it's going to flatten out beautifully. And the patient doesn't have to come back. They're thrilled that they don't have to come back. And I'm also thrilled that I don't have to worry in these young patients of track marks being seen with a 5-0 fast-absorbing gut. And then I also had another case where I took, I think it was a larger basal cell on the back, and I timed it. I think it also was about 10 to 15 minutes on the back. And I used the 3-0 monocryl interrupted suture, and then just quickly ran the 3-0 monoderm on top. And of course, very few passes because the needle's big, and many fewer passes than using the fast-absorbing gut, which often is my other go-to during the pandemic because I still don't want them to come back. I don't actually use the monoderm too much on the forehead. That's where I use the fast-absorbing gut. But on the cheeks and on the preauricular area, I'll use the monoderm superficial and deep. So in essential, in answering your question, Kathy, I'd say I increased my volume by 50% with my excisions at least.
Great, thank you.
And the biggest thing is it's just so reproducible. It's very reliable, and it's a great suture.
Great, we have a couple questions coming in. So I'll go to the first one here. The first question is, how reactive are the sutures? Do they spit much?
That's a great question. They don't spit. I've never seen any spitting sutures. And I don't think I've ever seen a patient coming back with spitting sutures.
Great. Next question is, other than increasing caseload, do you find any cost savings?
I think we've got some nice, do we have any information on the cost in the next slide? Maybe let's see if we can click to that one. Oh, here we go. Actually, maybe let's go one more. So here's a little slide that talks about the cost of Quill. And I thought I just would focus on some of the common sutures that all of us might use. Some of you might be using Vicryl, and that's about $8 on average. And of course, with the Vicryl comes the splitting issue. So I actually stopped using Vicryl a number of years ago and now only use the monocryl. And I know that many plastic surgeons use the monocryl. I actually learned about this from another dermatologic surgeon out in California. I've never looked back. So I use the monocryl, and that's about $11. And then on average, and of course, many of you might get something a little cheaper, maybe a little more expensive. The 5-0 fast absorbing gut is about $14. And then the Quill is about $18. So of course, it's a no-brainer when they're $18 if you want to use the Quill on its own for deep and superficial. But some people might think, well, if we're going to use the 4-row monocryl on the 5-0 fast-absorbing gut, you add those together, that's $25 versus maybe the 4-row monocryl and the monoderm, you're looking at $29. So you're looking at 25 versus 29, an average difference of $4. And when I compare those two, yes, those two, the 4-row monocryl and the monoderm together, are $4 more on average, but I'm getting so much more. So even though it's a little bit more expensive, for me, I save so much on time and patient satisfaction. I mean, patients are very, very satisfied with the cosmetic outcome. And they're not phoning, and I'm not worrying about track marks. So again, on summary, basically it's a $25 versus a $29 difference on average. And for me, it's very much worth it. And then of course, again, sometimes when I'm just using the 3.0 or 4.0 on its own, it just costs $18. So for instance, today when I used it on that cyst excision on the neck, I wasn't looking at $25. I was looking more just at $18.
Can you speak a little bit about what kind of needles and what lengths that you use?
Yes, I'll go to the previous slide. Let me go back here. So here's a list of the different quill sutures, the monoderm quill, the barbed sutures. And first of all, you'll see that they have the monoderm on the top half and then the PDO at the bottom. I don't use the PDO. I find it's often, obviously very strong, lasts for much longer. But I like to find a suture or use a suture that I can use in the deep and superficial areas, and I cannot really use the PDO for the more superficial part of the excision. So I just stick to the monoderm. And basically, if you focus on the middle of the slide, you see there's a 4.0 monoderm and a 3.0. And there's also a 2.0, but I just like to use the 4.0 and the 3.0. The 4.0, I use the P3 needle because I use the 4.0 in front of the ear, behind the ear, sometimes in the nasolabial fold. So I like the smaller needle with the 4.0. And then for the 3.0, I like the bigger needle because my incisions are bigger on the trunk. And also I need to have those deeper bites and bigger bites. So I like the PS2 and on the 3.0. And I actually choose the 20 centimeters length for both of them. So I did try the 30 centimeter in the past, but I found that it was not as easy to handle because the suture was hanging, flying in the air, and I wanted to get it out of my way. And the 20 centimeter length is perfect. It doesn't sort of get in my way. And even after an 8 centimeter excision, when I'm closing an 8 centimeter length excision, I basically have at least, I'd say half the suture left. So it's actually remarkably long for a very long incision. So I like to basically simplify, have just those two sutures in every single room. And I guess some of you can just try and see what works best for you. I would actually advise you to try the P3 on both the 4.0 and the 3.0, and just try the longer ones and the shorter ones. And I'm sure that you'll most likely come to the same conclusion that I have come to, that the 20 centimeter works very well and is very easy to use. But I definitely would think about trying maybe all of them, and then you can come to your own, find what you prefer.
Do you find anything special about the needles?
Well, it's very similar to the needles that I use for my monocryl. Obviously, I have a P3 and a PS2, so I'm familiar with the needles. And they certainly are better than the PC1, which I have for my fast-absorbing gut. That's obviously much more fragile, and I have to take so many more bites for the PC1 fast-absorbing gut needles. So I just like, I think the needles are great, especially the size, the fact that they're much bigger, the PS2 on the back when I'm doing the running subcuticular suture.
Do you use Quill in place of top sutures, not deep sutures?
Yes, what I do, as I might have mentioned earlier on briefly, I use the Quill for the deep running sutures and then the top subcuticular sutures. And that's when I just use the one suture. But I also can use the Quill in conjunction with the 3.0 monocryl interrupted sutures or the 4.0 monocryl interrupted sutures. So I'll use a different suture underneath and then the Quill running on top. Did that answer the question?
Yes, thank you. I see a couple questions in the chat, so let me just move over quickly. How are your results in the high tension areas, for example, groins? Do you use the 3.0 or 4.0? Do you use Dermabond or something similar?
So in the groin and other high tension areas, I will use definitely the interrupted suture. I'm not brave enough yet to do the 3.0 monoderm deep and superficial in those high tension areas, and I might, now that they've changed slightly and increased the barb percentage density, I might consider using that in the future, but definitely use the 3.0 as opposed to the 4.0, and then an interrupted suture, and then I use the 3.0 monoderm running subcuticular suture. And I don't think that you can really feel that thick, the fullness. You can't really, the fact that you use a 3.0, even in an area where the skin is quite thin, I don't really feel it on top. There's not much of a difference in the feel, especially when the person is very thin, between the 3.0 and the 4.0. So when I need the strength, I'll just choose a 3.0. There's no real downside to using the 3.0 versus the 4.0 in a high tension area. And I don't use any Dermabond. I like just to use the steri strips because it just gives that extra strength. And I don't need to use Aquaphor on the incision because there are no sutures on top. that are visible. So I just always will use very large steri strips to just keep that incision nicely opposed.
Great. One last question here. In your experience, what is the time frame for absorption?
It's about, I think, about 100 days, 90 to 100 days. So like monocryl. And one thing I would like to mention is that I talked about the use of the steri strips on top of my incisions in high tension areas. So I do not use steri strips when I'm doing the closure in front of the ear or behind the ear or maybe in the neck. I just add Aquaphor and the patient's done. And the barb suture holds everything together very nicely.
Great. I have another question here for you. Does Quill glide like monocryl or have more friction like Vicryl?
It's like the monocryl. It's beautiful. It glides beautifully.
Are you using the reverse cutting needles with plain sutures or only conventional cutting, not reverse?
I'm not sure about I think we use the fine reverse cutting needle for the P3 and PS2. That's what I use. I just use that needle.
Okay. Do you have any experience with scalp excisions with Quill?
I think I might have used the Quill once in the scalp. But for whatever reason, I just use nylons. I just find that because of the tension and the fact that sometimes I have a hard time putting the Quill in the subcuticular area in the scalp, I feel I need a little bit more. And I'm just out of habit, I use the nylons of the scalp. It's just, and of course I have to come back, but for whatever reason, I've chosen to use nylons in the scalp. But I'm sure some people could try it.
Okay. Do you use running subcuticular on the head and neck?
Yes, I do. I certainly do on the preauricular area. Sometimes the cheek. I did try it once on the forehead, and I didn't like the outcome. So I don't like to use it on the forehead. I just saw the suture too superficial. I didn't find the cosmetic outcome was that good on the forehead in my hands. And you might have seen I used it in the nasolabial fold. I think it looked really good there. And I do use it on the neck. Sometimes I use it in the mid-neck, and then over the clavicle I use it when I'm harvesting a large graft. So I definitely use it in the head and neck, but in certain areas. I choose my areas very carefully. And I wanted to add, basically, it's a great time saver with when I'm harvesting the grafts. Before, I used to obviously want to try and harvest the graft quite quickly, and sometimes there was a time when I just used to scoop out the graft down to fat and let it heal in on its own. But then the patient often didn't like it. They found it was painful. So for me, the benefit was it was a quicker way of getting the graft, harvesting the graft, but the patients didn't like it. And of course, putting in the interrupted monocryls and then the fast-absorbing gut takes a long time. And so I just started using the 4O monoderm, and it's incredibly quick. And patients are very happy. So whenever I'm harvesting a graft, it's always the monoderm, and it's just fabulous. It's like quick.
Great. I don't see any other questions come through. So that would conclude our Q&A section, but I do have one last question for you, Dr. Raynham. Do you have any tips on how to get started?
Yeah, I can actually also, I'm very happy to share my experience. Let me see if there's any, here we go. So what I would recommend, first of all, is get to know your local rep. I have a fabulous local rep, and her name is Katie. Thanks, Katie. So she actually introduced me to Quill, and she came into the procedure room for my first case, and I used then the interrupted sutures, monocryl, on the lower back, and then used Quill to close the top layer, just from one end to the other. And that's where I would start, because obviously the cosmetic expectations aren't as high in case you're not feeling confident. And it is a little scary for everybody trying a new suture. And then as I got more comfortable, I went into the upper back, to the chest, the arm, and then of course then onto the face. And a great place to start on the head and neck would be in the retroauricular area or even in the preauricular area. And of course, when I do those two areas, I use the 4O monoderm Quill for the superficial and the deep layers. So I think just start slowly. I'm also actually happy to give you some extra tips. Kathy, if you want to share my email, I'm happy to email some of our attendees if they have any extra questions.
Great, yes, great idea. I love that, thank you.
And then definitely get the patients back so you can see how they do. So, I found it very valuable giving them back. And then once I realized how reproducible the results were in my hands, then I no longer needed them back.
Great. I don't see any more questions coming in, so I can conclude the webinar. But as you mentioned previously, I'd love for other people to get to know their local sales representatives. And if anyone is interested in trying Quill for the first time, there is going to be a poll here that's going to be popping up on your screen. So if you'd love for us to get in contact with you, please hit yes and submit. Our sales rep will shoot you an email to start the consult. This kit will have 3 sample sutures and a practice pad to simulate a skin, and instructional video for you to follow along. And like I said, the sales rep will be with you through every step. So I hope everyone clicked yes. We'll contact you at the end of the webinar. And I want to thank Dr. Raynham for her time and for the informational talk. I hope everyone was able to learn something and take something back to their practice. So I hope everyone has a great evening. Thank you.
Thank you.